Thrombectomy 6 to 24 hours after a stroke with a mismatch between deficit and infarct. Definition: thrombectomy is the removal of a thrombus that blocks blood circulation. In many cases, it is an emergency procedure because permanent occlusion of significant blood flow to a vital organ can lead to necrosis. Other therapeutic options involve anticoagulation and thrombolysis.
Position the balloon guide catheter as close to the thrombus site as possible. Connect a rotating hemostatic valve, or RHV, to the fitting of the guide catheter, and then connect the continuous flush. With the aid of a suitable guide wire, hold the guide wire in place and advance the microcatheter. Position the microcatheter distal to the thrombus so that the usable length portion of the solitaire FR will extend past each side of the thrombus when fully deployed. Once the microcatheter is in place, remove the guide wire and tighten the RHV to secure the catheter. With the aid of fluoroscopic imaging, carefully advance the solitaire FR until its distal markers line up at the end of the microcatheter. To deploy the solitaire FR, loosen the RHV. Then carefully withdraw the microcatheter while holding the solitaire FR in place until the microcatheter tip covers only the proximal marker of the device. The usable length of the deployed solitaire FR should extend past each side of the thrombus. Tighten the RHV around the microcatheter. Angiographically assess the revascularization status of the treated vessel. Inflate the balloon of the guide catheter to occlude the vessel. To retrieve thrombus, slowly withdraw the microcatheter and solitaire FR as a unit to the guide catheter tip, while applying aspiration to the guide catheter.
Applications. Mechanical thrombectomy is indicated up to 24 hours after suffering a stroke. This technique can increase the probability of neurological recovery by more than 60%, allowing to reduce the mortality and disability that this disease supposes. Rapid restitution of cerebral blood flow is essential to minimize injury and reduce sequelae. In some cases, it is possible through the application of thrombolytic drugs that can achieve this dissolution of the clot if they are administered before 4.5 hours from the onset of symptoms. But when these drugs are not effective, it is possible to remove them using a device that captures the thrombus endovascularly, the so-called mechanical thrombectomy.
About every 40 seconds, someone in the U.S. will have a stroke. In fact, it's the fourth leading cause of death in America and a leading cause of adult disability. Since about 2 million brain cells die every minute during a stroke, timing is a huge factor in its diagnosis and treatment, often making this the focus of stroke-related litigation. This illustrated lecture instructs on the anatomy and pathology of strokes. It discusses the different types of strokes, diagnostic testing, available and effective treatments, and overall outcomes in order to examine claims of medical negligence from the defense perspective.
Proofs. Mechanical thrombectomy reduces disability, improves neurological outcomes, and increases the chance of restoring functional independence to patients who have suffered a stroke 3 months after having undergone the intervention. The mechanical thrombectomy procedure is fast and simple. The catheter travels through the central arteries of the brain, and when it hits the blood thrombus, it deploys and extends to capture and extract it. thus duplicate the recovery of the patient's physiological and cognitive functions from a stroke.
Time is brain. Think of a stroke as a forest fire. It starts small, it's gonna burn a few trees, and over time it's gonna burn the whole forest. Whatever has been damaged, you can't bring it back. What this mechanical thrombectomy does is you put the fire out, and you haven't really seen anything this big in the care of stroke patients. And in terms of treatment power, it's something that you haven't seen in neurology before. Your chances of being back to normal or near normal is close to 50% with the treatment. If you have no treatment, the chance is just like 13%.
You're not getting exposure on, I know why.
So essentially what you do is most of the time you go through the groin artery called the femoral artery. We get inside the blood vessel, and then under X-ray guidance you can guide that tube all the way to the neck. We shoot contrast dye, you then can take pictures of the brain blood vessels, locate the site where the blood clot is occluding the main artery, and then you would put the stent retriever. They essentially look like a wire mesh, and then the clot gets engaged, integrated in the wire mesh, and then we can remove everything as a unit. And then hopefully the blood clot is completely removed. That procedure can be as quick as 10 minutes to 20 minutes. This was a patient that actually came within the time window for the intravenous blood clot buster medication, the so-called TPA. However, because the clot was long and big, it was too big for the TPA to dissolve it. We were fortunate to very quickly remove the blood clot and see this wonderful response that immediately after the procedure, he had essentially gone back to normal.
My wife told me to blink both my eyes. I thought I did. She said I only blinked one. Felt like I blinked both of them. Squeezed my hand. Felt like I was squeezing her hand because your brain is sending the signal that you're doing it, but your body's not receiving it. So you're thinking you're doing something that you're not doing. Oh, I told her not to call 911, but I was slurring when I said it, so she wasn't gonna listen.
Initially, what you have here is, again, a complete occlusion of the middle cerebral artery, and these areas here, they are responsible for your movement, your motor function, specifically in the face and arm. So the blockage was exactly here, and you were missing out this piece here. So luckily, because you were able to reestablish the blood flow before the brain died, it regained the function.
It's my biggest fear because that's how my dad died. He was 55, I'm 36. Not expecting anything like that. I hear it's pretty far into some trouble there. I had to go somewhere else. I might not be talking right now. I do know in dealing with my dad's stroke, time means everything. Time lost is the worst thing. So yeah, it makes all the difference to be able to go to a place where they have everything you need there.
The big delays are before the patient gets through the hospital door, just because patients are not educated about strokes. They don't know the signs and symptoms. They don't know there is two very effective treatments that are extremely time sensitive. even when the patient activates 911, the system is still not optimized. Unfortunately, many people you come late to the hospital when the brain damage has already completed itself. It's about taking the right patient at the right time to the right place.
Cons. All surgeries have risks. Some of these include excessive bleeding, infection, damage to the blood vessel, inability to remove the clot and need more extensive surgery, reaction to anesthesia, long-term venous problems, pulmonary embolism, and formation of another blood clot. Conclusion. Endovascular treatment by mechanical thrombectomy has shown high efficacy. In the future, in the short and medium term, the times will be shorter so that more patients can benefit from the treatment and those that are treated have better clinical results.
One second. So listen, he has a distal M1 occlusion, okay? So we should activate the cath lab.
What is your name?
So we call this a distal M1 MCA segment occlusion. This carries a poor prognosis if it's untreated. He will receive intravenous TPA, but we're not waiting for TPA to work. So we're going in, and if there's persistent occlusion,